We are live.
Good evening, everyone. Welcome to iFocus Online Lecture 184, and this is the Retina session 36. And today we have with us Dr. Aditya Kelkar, sir, who will be talking on hypertensive retinopathy. I request Dr. Ritesh Narula, sir, to please introduce Dr. Aditya, sir.
Thank you, Rolika, and a good evening to all. It's indeed a pleasure to welcome Dr. Aditya Kelkar from National Institute of Ophthalmology, Pune, the medical director of the institute. And it's my honor to introduce him. He is a graduate and postgraduate from Pune, following which he did his Retina Fellowship from Retina Foundation, Ahmedabad, and has number of international fellowships to his credit, such as ICO Fellowship, FRCS, FACS, and FASRS, right? And his specialization is predominantly in vitreoretinal surgery, phacoemulsification. He has been extensively involved in doing a lot of lectures for graduates and postgraduates with publications. He has also received a number of rewards from APO, IGO Gold Medal Award, the Reed Buckler from ASRS, and the VK Chitnis Oration Award by Maharashtra Ophthalmic Society. Today, he would be speaking with us on hypertensive retinopathy, a topic which is, though a very important one in terms of exams for postgraduate, even for experienced of retina surgeons at times, it's very difficult to differentiate the hypertensive from diabetic. And we are really looking forward to listening to him and to see all the aspects that he's able to touch upon and make us understand the basics of hypertensive retinopathy and its features. Over to you, Dr. Aditya.
Thank you. So I hope you are able to see the slides, then I can move on to the topic.
Yes, sir.
Yeah.
All right. First of all, thank you, Dr. Santosh Honawar, sir, and the team Center for Sight, Dr. Ritesh and Dr. Rolika for having me here with you all. So today's topic is about hypertensive retinopathy. As you all know, this is one of the commonly asked questions in the DNB exams and even the postgraduate MSMD exams as well. So this is how the lecture is going to proceed today. First of all, we'll have a look at the epidemiology, then etiology, risk factors, pathogenesis, the staging and classification. And apart from hypertensive retinopathy, we also have hypertensive choroidopathy, optic neuropathy, and the relationship with various conditions, some clinical scenarios, management, and then conclusion. So as you know, hypertensive retinopathy is a condition which is characterized by a spectrum of retinal vascular signs in people with elevated blood pressure. First described by Marcus Gunn in 19th century, a series of patients who have hypertension and renal disease. He identified the changes in the retina, and atherosclerotic changes of the hypertensive retinopathy are caused by the chronic elevation of the blood pressure. And hypertensive retinopathy includes two disease processes. First of all, the acute phase where there is vasospasm, and that leads to autoregulation perfusion. And then the chronic stage where atherosclerosis, and then it predisposes the patients to vision loss due to complications such as vascular occlusions and microaneurysms and macroaneurysms. So first of all, the blood pressure can be categorized into three. First is elevated blood pressure, when you have blood pressure of 120 to 130 and less than 80 diastolic. And then stage 1 hypertension is when the blood pressure is between 130 to 139 and the diastolic is 80 to 90. And the stage 2 hypertension is when you have blood pressure of more than 140 and 90 millimeters of mercury. Worldwide, this problem is very extensive, and approximately 1 billion people worldwide are suffering from hypertension, and it is one of the most modifiable risk factors for stroke. More common in African Americans and Chinese descent, and obviously in India, you do see a lot of people who are overweight and they do suffer from hypertension as well. When it comes to age and gender, the people who are less than 45 years of age, it is observed that men are more commonly predisposed to blood pressure than women, whereas after 65 years of age, women are more predisposed to blood pressure than men. So the atherosclerotic changes of hypertensive retinopathy are caused by chronically elevated blood pressure, which is defined as more than 140 by 90. There are different types of hypertensions. The primary hypertension is usually the essential hypertension and not secondary to any other disease process. Essential hypertension is polygenic disease with multiple modifiable environmental and mental stress factors which are contributing to this type of disease. And then the secondary hypertension, which is developed usually due to secondary causes such as pheochromocytoma or hyperaldosteronism or Cushing syndrome or renal parenchymal disease or renal vascular disease or certain other cardiovascular elements. In addition, there are genetic factors which are associated with higher risk of hypertensive retinopathy. What are the risk factors for hypertension? Obviously, the high salt diet, obesity, tobacco use, alcohol, family history, stress, ethnic background, the duration of blood pressure, the degree of blood pressure elevation, and the genetic factors. These are all the risk factors for developing hypertensive retinopathy. So why is it so important to identify and document hypertensive retinopathy? First of all, it's an indicator for systemic mortality and morbidity. Mild hypertensive retinopathy signs such as generalized and focal retinal narrowing and arteriovenous nicking are weakly associated with systemic vascular diseases, whereas the moderate hypertensive retinopathy signs such as microaneurysms, hemorrhages, cotton wool spots, these are all signs which are strongly associated with subclinical cerebrovascular disease and can predict incident stroke, congestive heart failure, and also cardiovascular mortality, independent of risk factor and other traditional risk factors also. Coming to pathogenesis, so there are different phases. First phase is the vasoconstrictive phase. It's the initial response of vasospasm due to increased blood pressure. It is due to increased vasomotor tone, leads to consequent narrowing of the arterioles, and clinically you can see it as a generalized or a diffuse arteriolar narrowing. So here on the left hand side, you can see a young person who's normotensive, and you can see the AV ratio is 2:3. Whereas a picture on your right is a patient who is 60 years old and he's hypertensive, and you can see the arteriolar narrowing very clearly. When you compare it with the picture on your left, you can easily make out that there is significant arteriolar narrowing seen in the picture. Coming to the next stage is the sclerotic phase, and that's due to the persistent elevation of the blood pressure, pathologically seen as intimal thickening, medial wall hyperplasia, and hyaline degeneration. And clinically, it is seen as diffuse or focal arteriolar narrowing, arteriolar wall opacification, commonly known as silver wiring or copper wiring of the vessels. And you also see compression of the venules, because the arteries and venules, they have a common adventitial sheath, and therefore you can see those AV nicking or nipping changes. Also, you can see what is commonly known as the Gunz sign, where the tapering of the retinal vessels is seen on either side of the AV crossing. Or you may also see a slight deflection, and it is called as Salu's sign. Then the third phase is the exudative phase. Like here, the chronically elevated blood pressure leads to blood-retinal barrier breakdown. And then pathologically, it causes necrosis of the smooth muscles and endothelial cells, exudation of the blood and lipid, retinal nerve fiber ischemia, which clinically is translated as microaneurysms, the leaky outpoaching of the capillary walls, retinal hemorrhages, hard exudates, and the cotton wool spots. Then comes the fourth stage, that's the malignant hypertension, where all the stage 3 signs are there, along with the optic disc swelling. So here you can see the blurred disc margins, and also you can see hyperemic disc. And apart from that, the changes such as inflammation, endothelial dysfunction, abnormal angiogenesis, and oxidative stress may also be present, and these patients can in long term lead to proliferative disorders also. Coming to classification of hypertensive retinopathy, there are different types of classifications. So first of all, the most commonly used is the Keith-Wagner-Barker's hypertensive retinopathy classification. And there are different grades. Grade 1 is the milder hypertension, where it's a generalized narrowing of the vessels, as you saw in the previous picture. Then comes the grade 2, where the hypertension is more, hypertensive retinopathy is more marked, and there is focal narrowing, and plus you can see the crossing changes like Gunz and Salu's sign and exaggerated arteriolar reflex. Then comes the third stage, where you have, in addition to stage 1 and 2, you have retinal hemorrhages, exudates, cotton wool spots, sclerotic and spastic lesions of the retinal arterioles. And when it comes to stage 4, it is all the three signs, stage 3 signs plus the disc edema. And when it comes to stage 3 hypertensive retinopathy, generally patients will have some symptoms such as systemic as well as ophthalmic sometimes. And stage 4 obviously is a very serious condition and needs immediate referral to a physician. So this group again also classified hypertensive retinopathy based on the OCT characteristics into mild, moderate retinopathy or malignant retinopathy without subretinal fluid and malignant retinopathy with presence of subretinal fluid. And this classification could be correlated also with the visual acuity of these patients. Then the Sheets classification was done for the malignant hypertension, where grade 0 is no changes, grade 1 is barely detectable arteriolar narrowing, grade 2 is obvious narrowing with focal irregularities, grade 3 is grade 2 plus retinal hemorrhages, exudates, cotton wool spots and retinal edema, and grade 4 is obviously papilledema and the grade 3 signs as well. She's also classified the atherosclerotic hypertensive retinopathy changes, chronic atherosclerotic changes such as widening of the arteriolar reflex. Then stage 2 is stage 1 plus AB crossing sign. Stage 3 is copper wiring of the vessels, and stage 4 is the silver wiring of the arterioles. So this is the way you can classify the atherosclerotic changes in patient's retina. Then classification by Michel and other group members was to correlate the hypertensive retinopathy and systemic association. So stage 1, where there is no retinopathy and there is no systemic association, mild retinopathy is then associated with a modest risk of cardiovascular disease. Whereas with moderate retinopathy, you can have a strong association with clinical stroke or subclinical stroke or cognitive decline and cardiovascular morbidity. Whereas malignant retinopathy or stage 4 has a strong association with morbidity. So this is the way the Michel and group have classified hypertensive retinopathy and its systemic association. Coming to the pictures again, so this is what the mild hypertensive retinopathy would look like. You can see a focal narrowing and AB nipping changes, and then you can see silver wiring and copper wiring vessels of the vessels here due to opacification of the vessels. Superficial hemorrhages are seen here, and you can see also the cotton wool spots in this picture. Coming to the stage 4, where you have signs of moderate retinopathy along with the disc hyperemia and blurring of the disc margin. And you can also see the extent of ischemia. Many of the times these patients have a lot of cotton wool spots along with the superficial hemorrhages and hard exudates. So the hypertension not just affects the retina, obviously it will affect the choroid also, and you see some interesting signs such as Segrist streaks and Elschnig spots that you can see in this picture as shown on your right. And also the hypertension will lead to optic neuropathy or the optic disc swelling, and the signs will be flame-shaped hemorrhages, blurring of the disc margins, and also along with that the patients may have reduced vision. So these are the patients who require urgent referral to the physician and they need urgent antihypertensive treatment. Another interesting aspect is pregnancy-induced hypertension. Nearly 10% of the pregnancies are having pregnancy-induced hypertension, and malignant hypertension and exudative detachments are also seen in some patients. In these cases, obviously the physician's drug of choice is methyl-dopa, and you may come across a patient who has exudative detachment and is also pregnant. You must always check the blood pressure before doing anything else. Now coming to a few interesting cases, this is a 23-year-old female who presented to us with sudden decrease in vision in both eyes. The right eye vision was 6/15 and the left eye was 6/12. After we did the dilated examination, retina examination, we found that there is hyperemic disc on both sides. You can see the superficial hemorrhages also and multiple cotton wool spots. And the blood pressure that was recorded on presentation was 223/116. This patient was then referred to a physician and was then diagnosed as having hypertension secondary to a renal disease. You can see the Keith-Wagner's classification grade here. As per the OCT, this patient has the presence of subretinal fluid. So obviously it goes in favor of the stage 3. And as it correlates with the visual acuity of the patient, again, you can see that the visual acuity of the patient is reduced, in this case 1. So after the treatment, this patient has all signs reversed. So this is very interesting. Many a times diabetes, in spite of good control of sugars, the signs do not reverse. Whereas hypertensive retinopathy is one condition where after, especially the acute hypertension, where after good control of blood pressure, within 6 months, you can see that the patient's fundus looks almost like a normal fundus. Although you may still see some opacification of the vessel borders or sclerosis of the vessels, but that's due to the chronicity of the condition. Coming to another interesting male who came to us with sudden diminution of vision. He's 55 years old and hypertensive, and he also had recent history of COVID vaccination. Now, these are again thromboembolic episodes that we commonly associate with either COVID vaccination or COVID per se. And you do see patients coming up with vascular occlusions, artery or vein occlusion. What is interesting in this patient is that this patient also has a branch retinal artery occlusion. That's why you see a sectoral whitish area here of retinal edema, superficial retinal edema. You can see disc edema here, and you can see all these vessels are also tortuous, indicating that it's more like a central retinal vein occlusion with branch retinal artery occlusion. And you can see there is cystoid as well as intraretinal as well as serous retinal fluid. And this patient was treated with intravitreal Dex injection. The hemorrhages and retinal swelling has resolved considerably. The signs of ischemia are still present. However, the macular edema, as you can see, is much better. But this is a patient who, because of the existing ischemia, needs a longer follow-up. It's quite likely that these patients may not do well, although after initial Vasodex injection, his macular edema has settled. But the ischemic process may be still lingering behind, and these patients may end up with proliferative stages and also neovascular glaucoma. So these patients need to be warned about close, consistent follow-up and also monitoring of his blood pressure and other systemic parameters. Coming to another interesting patient who presented to us with a slight decrease in vision, both eyes. His age was 65, 6/18 vision and 6/12 vision in the left eye. Some pigmentary changes are seen on the autofluorescence here, but they are basically due to the age-related dry AMD changes. But apart from that, what interesting thing here is that the patient has blurred disc margins. And again, you don't have to label all patients of this blurred disc margins as hypertensive retinopathy or intracranial hypertension. As you can understand here, this patient is a hyperope. So this is more like a pseudo-papilledema. And this patient also has some choroidal folds, as you can see, retinal folds, as you can see in some patients of high hypermetropia. You do come across these retinal folds. As you can see on this OCT, these folds are very evident on both sides. So you should correlate with this patient's hypermetropic status before subjecting this type of patients into systemic investigations. Coming to another interesting patient who is a 60-year-old male with his blood pressure of 160 on 100 on treatment, on irregular treatment. He presented to us today with disc margins blurred, and you could also see these choroidal infarcts here, these whitish areas, indicating the acute nature of this elevated blood pressure probably. But at the same time, he also has these AV crossing changes. So this is more like a chronic plus acute, acute changes over a chronic pre-existing condition. And probably that is described, clinically evident because of his irregular treatment of his hypertension. Recently, there are a few new analysis softwares that are available nowadays for patients monitoring. Especially the arteriolar narrowing is one of the most important signs of hypertensive retinopathy, which can be assessed by taking serial photographs, and a computer software can analyze the extent of retinal narrowing. Also, you can see the branching of the angles, bifurcation, the fractal dimensions, tortuosity, and the vascular length and diameter ratio and wall to lumen ratio. All these parameters would also go a long way in trying to find out whether a patient is likely to develop any cardiovascular morbidity or mortality. So similarly, at cellular level also, you can see retinal imaging using the adaptive optics and retinal vessel oxygen saturation using retinal oximetry, and then flicker light induced vasodilatation. All these instrumentations or investigations which are in the pipeline now might find some clinical relevance once they have an established role in our clinical setup. So there is a differential diagnosis of hypertensive retinopathy that you may want to write in your theory exams. Basically, clinically, it's more or less a straightforward situation when you face a patient of hypertensive retinopathy. But yes, you must know that diabetic retinopathy, radiation retinopathy, anemia, other blood dyscrasias, and ocular ischemic syndrome, retinal vein occlusions, all these are considered as retinal pathologies which are like differential diagnosis of hypertensive retinopathy. Also, the patients who have optic disc edema, which is like diabetic papillopathy or anti-ischemic optic neuropathy or neuroretinitis, can also be a differential diagnosis of hypertensive optic neuropathy. Now, this is a patient who obviously has a diabetic retinopathy. You can see cotton wool spots and superficial and deep hemorrhages and tortuosity of the vessels. And he does have correlating, coincidentally, hypertension also. So you may see a lot of AV crossing changes as well in this patient. This is a patient obviously who has a central retinal vein occlusion. You can see superficial hemorrhages in all 4 quadrants. And this is another patient who has a sclerosed vessel running on the nasal side, and as a consequence of hypertension, he also has an extensive branch retinal artery vein occlusion with sclerosed vessel, with probably a small neovascularization front leaking here. Another patient who with a bilateral multiple branch vein occlusions. You can see branch vein occlusion on the left side. On the right side, he already has an inferior branch vein occlusion, which seems to be an old one, whereas this seems to be a fresh branch retinal vein occlusion. Along with it, also you can see a few cotton wool spots indicating that it's not just the exudative process, but also slight amount of ischemia exists in this type of patient. You can also see a few abnormal new vessels developing in this area, which would probably may go on to cause a vitreous hemorrhage and may require patients to have laser sessions. This is another young male who presented to us with central retinal artery occlusion. You can see a lot of cattle trucking and sclerosed vessels here, and cotton wool spots, retinal edema, and slightly hyperemic disc margins. And you can also note that all the arteries here, they don't have any perfusion, especially in the peripheral areas. They're all choked out. This is another interesting lady who presented to us with sudden decrease in vision, and it is secondary to it's a subhyaloid hemorrhage that you can see, and it has bled from retinal macroaneurysm along the superotemporal vessel. So all this can be due to as a consequence of hypertension. Coming to management, generally you don't require ophthalmologists to treat any hypertensive retinopathies, except if there are consequences such as central vein occlusion, artery occlusion, or macroaneurysm or branch vein occlusions. Only then we may have to treat these patients from the ophthalmic point of view. But our main role is to identify these signs of hypertensive retinopathy and timely referral to the physician. Also, the treatment of retinopathy, as I said, is basically controlling the blood pressure, which is not our job, but referring the patient to the physician timely is most important. And then the physician would lower the arterial pressure by 10 to 15% within first hour. And then generally we should have an aim of lowering the blood pressure to less than 130 and 80 in the next 2 or 3 months. That's what generally the physicians would be doing. So this is the primary treatment and prevention. Then the medical therapy and follow-up would obviously be with the physician, and ACE inhibitors and calcium channel blockers and diuretics. These are some of the antihypertensive agents which the physicians would be using. And surgery obviously is not required in any of these cases as an ophthalmologist. Again, coming to grade 1 hypertension, that is the blood pressure which is between 130 and 80, routine care, lifestyle management, and that's all. And consider ophthalmic referral. So this is from the physician's point of view. Consider ophthalmic referral only if patient has some something like white coats hypertension. Otherwise, he can just modify his lifestyle. Grade 2 hypertension, again, to remind you, this is a blood pressure less than 140 by 90, but more than 130 by 80. So this is grade 2 hypertension. Again, patient has to do lifestyle management. Consider ophthalmic referral if the patient has mild retinopathy or moderate retinopathy. Then again, more vigilant cardiovascular risk assessment. And if the patient has moderate retinopathy, which means patient has cotton wool spots or superficial hemorrhages, then he needs to undergo aggressive risk reduction, and also possible indication for starting the antihypertensive treatment, obviously, which would be in the domain of the physician. Coming to grade 3 hypertension, which is more than 140 by 90, again, the patient is more likely to develop retinal vein occlusion and non-arteritic AION, and therefore ophthalmic referral on routine basis is definitely a must in these type of patients. Whereas a malignant retinopathy or grade 4, as you can understand with the papilledema, The ophthalmic referral here is mainly to document the changes in his retinal situation, and the treatment would be on urgent basis by the physician. So once again, to conclude, the risk of stroke retinal circulation shares anatomical, physiological, and neurological features of cerebral circulation, and therefore it is important to identify these retinal signs and refer the patient on time. Hypertension predisposes the patient to many retinal vascular diseases such as retinal vein occlusion, artery occlusion, as we have seen in some of the cases that I discussed with you previously. Also, ischemia secondary to vascular occlusion can cause neovascularization, vitreous hemorrhage, and ERM formation, tractional detachment. So all these things will happen if the patient has the above mentioned conditions, and therefore these patients require regular follow-up care with the ophthalmologist. All right, and recently another term that has been coined is the proliferative hypertensive retinopathy, which would interest the ophthalmologist, but this is generally secondary to conditions such as branch vein occlusion or central retinal vein occlusion, which later on leads to proliferations, and then if untreated can end up in vitreous hemorrhage and neovascular glaucoma. So it's important to identify these patients on time and monitor them regularly, and also refer them to physician before all this end organ damage occurs. So as you know, retina provides a window to study the human circulation. The retinal arterioles can be visualized easily and non-invasively, and they share a similar anatomical and physiological properties to coronal and cerebral microcirculation, and therefore the retinal vessels are often correlate with the health of cerebral and cardiovascular health of the individual. BP must be emergently controlled to decrease the risk of developing heart or end organ damage. You can call it like heart disease or renal failure. And therefore, in patients who present to you in OPD with disc edema and other hypertension retinopathy signs, they must be referred to the physician within as early as possible. So these are some of the references that I have used to prepare for this lecture. So with this, I thank you and thank Team Center for Sight. Now we can have question and answers if there is any.
Thank you so much, sir. Thank you for covering such an important topic. And as you said at the beginning itself, that it is a very important topic at every level, even if it is Viva or even if it's a long question, short question, everywhere it can pop up, even in OSCE. And I'm glad the way you've described the first slide itself, which has all the headings summarized. If the postgraduates remember those, it will be extremely helpful for you to outline your answer. Dr. Ritesh, sir, would you like to say something?
Sure, I think I can see some of the questions here in the chat
Yes,
box.
sir.
Should we go on
Yes,
answering them one by one?
Sure, sir. First, Ritesh, sir, would you like to say something, and then we'll take up the questions.
Aditya, thank you for such a lucid talk. It was really interesting and really covered the topic very nicely. And the questions are also, I'm also seeing they're quite interesting questions coming in. Let's straight away go there, Rolly.
All right, good.
Okay.
Fine. Then we have the first question, I think, here by just a second.
Would you like me to take it, sir? Or
all right, you can take it so that it becomes easier. If I have to switch back to the slides, I can publish them.
Okay, so the first question is by Dr. Soni, that she's asking that how do we appreciate the exaggerated light reflex?
Yes, so I just go back to my slides and probably show her exactly what exactly I mean by exaggerated light reflex. Now you can see that when you look at this blood vessel here, okay, it's a blood vessel of a young individual, and you can almost see the entire blood column here. So as if there's no reflection seen at all, right?
Right.
And when you have this kind of a sclerosed vessel, you obviously can start seeing the whitening of the vessel. So this is like an exaggerated white reflex. Also, you can see when you do a direct ophthalmoscopy, the vessel will start shining right in the center. This vessel will appear very shiny. So if that shiny area appears wide, that is also considered as an exaggerated white reflex. Like here, you can see it's like an exaggerated white reflex. In this slide probably would be a better explanation of exaggerated white reflex.
Okay, sir. So another question from Sony is that is tortuosity of vessels a significant change?
Tortuosity of the vessels is, clinical. Like for example, here you can see there is some tortuosity of the vessels, but you do see tortuosity of the vessels in many of the individuals, and it may not be considered alone as a significant factor. However, if tortuosity is associated with hemorrhages, like in this patient, then it becomes significant. But tortuosity of the vessels alone per se does not carry any significance as such.
Can I add a point here? Just a
Yes.
small
Please.
apart from tortuosity, if the tortuosity is also associated with dilated vessels, especially if some are dilated and the others are not, that should raise more suspicion. Tortuosity, as just rightly Dr. Aditya said, it can be a normal feature also in some individuals. So if you have a dilated tortuous vessel, then you can be a little suspicious about things.
So another question that has popped up in association with the first one, that is like, what is the cause of the exaggerated white reflex?
The cause of exaggerated white reflex is again the atherosclerotic changes that you see in the vessel. So probably the blood column is not seen reflecting back.
Right. So another question is there that can we say that mixed retinopathy we have both diabetic and hypertensive retinopathy features?
So in mixed retinopathy, you will have diabetic and hypertensive retinopathy features together. Yes.
Yeah.
So you want to understand how to differentiate between hypertensive and diabetic, or
I think the question was just about mixed retinopathy in general, but I think it would be nice for the postgraduates if Dr. Ritesh and you can add about the
you can see that hypertensive retinopathy, you would consider the retina is slightly drier compared to diabetic retinopathy, where the retina appears more wet. So for example, here you can see that the retinal blood vessel changes, cotton wool spots, and a few scattered superficial hemorrhages. This is an indication of a hypertensive retinopathy. As against if you see a patient who has hard exudates, microaneurysms, dot and blot hemorrhages, most interestingly. So this would go more in favor of diabetic retinopathy. But there are patients who have coexisting diabetic and hypertensive status in as according to their health parameters. So there you may have patients having mixed retinopathy also, where you will see superficial hemorrhages, cotton wool spots, and along with that, the diabetic retinopathy changes as well.
Dr. Ritesh, would you like to add something?
Yeah. Just a couple of more points here. Another thing, relative distribution in terms of hemorrhages, you'll see a lot more nerve fiber layer hemorrhages with hypertensive, and you see a lot more microaneurysms with diabetes. So that's one way to differentiate. Also, one can look at the distribution of these hemorrhages. The hypertensive retinopathy hemorrhages can be distributed along a vessel compared to diabetic retinopathy changes, which are more kind of central and more around the macular area. And yes, as Dr. Aditya said, they coexist, and then it becomes a little difficult to differentiate the two also totally. But yeah, so two main points which I look at is generally the amount of nerve fiber layer hemorrhages versus dot and blot and microaneurysms and the distribution.
Okay, so thank you for that. So the question that Sony has asked next is that on a slit lamp fundoscopy, which I think she means by 78D or 90D, how do we differentiate between pre-retinal, intraretinal, and subretinal hemorrhages? Okay, so
pre-retinal hemorrhage, as I think I can probably share with you that slide which I showed about macroaneurysm. Okay, so you can see this is a pre-retinal hemorrhage, right? Again, a pre-retinal hemorrhage here. You can see the blood vessels are obscured, right? What you can see here next to the vessel is the intraretinal hemorrhage. And anything else you want to know?
I think the three were subretinal, pre-retinal, and
subretinal would be appearing more darker. It would be toward brownish red types, whereas this is like a superficial intraretinal hemorrhage, so it's more brighter. And here also you can see a blood clot, and therefore you can see a blood vessel going over it, and so it is intraretinal or subretinal. Whereas this vessel is lying under the hemorrhage, so it is intraretinal. again a boat-shaped subhyaloid hemorrhage here, which is intraretinal, supraretinal, or you can say subhyaloid.
Right. So another question is that Dr. Ritesh, would you like to answer this? That in hypertensive retinopathy, would you like to do a cataract surgery, and what would be the risks involved?
So there are two things. One, when you're talking about hypertensive retinopathy, and if the hypertension is persisting and their blood pressure is high, I would definitely not be going in for a cataract surgery. One, the risk is obviously to the eye. That is one risk. The other risk is in case you need to give a block or something, you will always have a risk of in peribulbar block of orbital hemorrhages, and so that risk is there. You don't generally enter and try and give a block in a patient who has had such a severe hypertension to lead to retinopathy. With regards per se, the eye changes in any such conditions which are kind of inflammatory vascular. If you tend to do a cataract surgery, you're going to increase the chances of exudation, post-operative edemas, and drop in vision post-surgery. Even there would be risk of, if there's pressure fluctuations during surgery, you may sudden decompression also, or a sudden rise in pressure can either lead to a vein getting burst and landing with a vitreous hemorrhage, or can lead to an arterial block if already the hypertensive changes are there and the IOP also goes up high during surgery. You may land up with arterial occlusions. So first go, I would control, and cataract surgery is not an emergency that you're in such a hurry to do it.
Aditya, sir, what's your take on this?
Yeah, like if you have grade 1 and grade 2 hypertensive retinopathy changes, there's nothing like stopping you from doing a cataract surgery, which is again after control of blood pressure, obviously. And if you have malignant hypertension, obviously cataract surgery is not a priority. So you would want the physician to get the blood pressure under control, let the systemic condition stabilize, then consider patient for cataract surgery.
Right. So
like diabetic retinopathy gets priority over cataract surgery. Here hypertensive retinopathy in first or second stage, where it's only about arteriolar narrowing, focal or generalized, it doesn't really matter.
right. So and so is arteriolar attenuation reversible?
See, ultimately it's also an indication of atherosclerosis. So per se, it won't be reversible. Over time, these changes would continue. AV crossing changes and arteriolar narrowing would continue with age.
Okay, so Dr. Divya has a question that is it difficult to identify the salus in the bonnet sign, and how to differentiate between these two?
No, it's not at all difficult to differentiate between bonnet sign and salus sign. Salus sign, you can definitely see a deflection, and bonnet sign, you will see tapering at both sides, on both sides. It's extremely easy. I think more you do a 90-day examination, you look for it, then it won't be very difficult.
Okay, so so Dr. Soni has asked that why is it so that nerve fibular hemorrhages are more in the peripapillary area?
Interesting question, but I really don't have an answer to it.
Ritesh, would you like to comment?
Yeah.
Obviously, one will have to go and cross-check this answer, what I'm telling, but the chances may be because in hypertensive retinopathy, probably we are getting more central or larger vessel involved, so which are there in the peripapillary area. Plus the nerve fiber layer is more compact there, so the arteries don't have that much of space, so the pressure around that artery or vein is much more. So that's probably one of the reasons that you have the peripapillary area, which has more hemorrhages in hypertensive retinopathy. But yeah, I'll also have to go and check this question. Interesting one.
Right, so Dr. Kavya's question was that can tortuosity of vessels be physiological? I think you've already mentioned that, so that it can be physiological also. Dr. Meenal has asked that are NSAIDs like nebuphinac drops of any use in the treatment of mild or moderate hypertensive retinopathy?
In fact, mild or moderate hypertensive retinopathy per se doesn't require any treatment, so there's no use of giving any drops.
Right, so Dr. Praveen has a question about the role of anti-VEGFs in hypertensive retinopathy.
There is no role of anti-VEGFs in hypertensive retinopathy. You just have to control the blood pressure. The role will come only if the patient has consequences such as branch vein occlusion or central vein occlusion. That's an indication of anti-VEGF. Per se, hypertensive retinopathy doesn't have any indication.
Right, so another question is that if you see an elderly hypertensive with dilated tortuous retinal veins, what would you do? Is there anything that can be done for the impending vein occlusion?
Again, as Dr. I mean, I wouldn't say that dilated tortuous vessels are always an indication of a impending central vein occlusion. But if the patient has not had any cardiovascular workup in the recent past, then yes, we should ask the patient to visit a physician and get his cardiovascular system checked.
Okay, so another question, that what age group is hypertensive retinopathy classification made for? Does it apply practically for elderly, or is it applicable for all age groups?
See, ultimately what happens is, in younger age group, the hypertension generally manifests as an acute disease, and then it goes into the malignant type of an hypertension type of a condition. Whereas in elderly, the hypertension proceeds as a chronic disease, and then it may go from stage 1, 2, 3, depending on the degree of hypertension the patient has. So from that point of view, the hypertensive retinopathy would be different in a young patient and an elderly patient.
Right, sir. So is it possible to get hypertensive retinopathy even if the blood pressure has been under control?
No, I don't understand the question. I'm sorry, once again, please.
Is it possible to get hypertensive retinopathy changes even if the blood pressure has been under control?
Yes, it is possible to have stage 1, stage 2 type of hypertensive retinopathy changes, and they are also due to atherosclerosis. Even if the blood pressure is under control, these changes would be visible. Whereas stage 3 and stage 4, where you have superficial hemorrhages, cotton wool spots, optic disc edema, these changes can be reversible. Like I showed you in one of the case presentations earlier on.
Right, so there's another question that when the patient gets diagnosed, like what is the, like say the patient gets diagnosed with hypertension, what is the interval of screening that you would prefer? And when do we start screening, at the time of diagnosis or even before that, and in which patients?
I think I'll go back to the slide that I shared earlier on, which talks about what you should do with hypertension patients. Let me. This one. So this would be a useful slide to copy, which tells you exactly what to do. Maybe you can take a screenshot of this. It will be easy for you to find your answer.
Dr. Deepti, would you like to ask some questions? I believe you have some questions too.
Yeah, I just have one practical question mainly. Dr. Aditya, this is a common scenario where patients are referred to an ophthalmologist for an evaluation right before a kidney transplant if they are a potential kidney donor. So now the physician is probably looking for hypertensive retinopathy changes in the fundus. And then suppose it's an elderly patient, say somebody in their 50s. Of course, if they're above 60, they automatically do not qualify to be a donor. But if they're in their 50s and they probably might still have hypertensive changes or even age-related changes.
Yeah.
I mean, age-related changes and not hypertensive changes, say great arterial attenuation or mild AV crossing changes. Now, do you strictly say grade 1 hypertensive changes or grade 2 hypertensive changes? Because once you say that, then they get labeled as someone who has an end organ damage and they are disqualified. So what would you do in that situation?
So this is the classification that's going to come and help us out with this type of situation. So as you understand, when there is mild retinopathy where you have only generalized or focal narrowing, what it says is that it's a very modest association with risk of clinical stroke or subclinical stroke or coronary artery disease or mortality or morbidity. And the same thing would apply to a renal disease too. So I think in patients who have got only focal narrowing or generalized narrowing, they should not be labeled as a contraindication for renal transplant donor.
Right.
Whereas if the patient has this moderate type of retinopathy, like microaneurysms, cotton wool spots, hard exudates, then yes, these are the patients who may have some association with renal problems too, because they have these cardiovascular morbidity risks.
Right. So as of now, you would just say that they're appropriate for age.
Yes.
Thank you for that question, Deepthi. There's another question by Dr. Mindal, and that is that does serous RD in eclampsia patients need any active intervention?
Not really, because this is going to go away as soon as the patient delivers. The serous detachment also would settle.
Right, so Dr. Soni has it out that in clinical diagnosis, we should mention the grade of systemic hypertension with retinopathy classification.
I'm sorry, can you please repeat the question?
Could you take that question, because I believe you wanted to ask something, but it has not really come across. Soni? Yeah.
Yes, ma'am. Sir, I meant that we should mention the grade of systemic hypertension along with grade of retinopathy. Both should be mentioned, or we can mention right away retinopathy gradings.
If you're talking about the exams, you should write only about the retinopathy gradings, because I think the hypertension gradings is something which a physician should do. But it's not very difficult if you want to write it along with your findings. No harm done.
Right, so.
Okay, thanks.
So in pregnant women, how often do we have to follow up for the hypertensive retinopathy component?
We don't have to follow up these patients unless symptomatic. And again, if the patient has significant, blood pressure which is more than 140/90, then these patients are to be referred to the ophthalmologist for a routine referral. This is not urgent referral at all, unless the blood pressure is more, it's like a malignant hypertension and the physician wants to see if the patient has developed any signs ophthalmically. Otherwise, it's a routine referral.
Right, so. So there's another question on the component of disc edema. So disc edema differentiation from other causes with hypertensive retinopathy, how do we do that?
So now another interesting disc edema, one will be papilledema, which is caused by the raised intracranial hypertension or any intracranial tumor. And then secondly, you will have papilledema, which is caused by hypertensive changes. So with hypertensive changes, you can see more amount of cotton wool spots and other changes which are grade 3 hypertensive retinopathy changes, such as microaneurysms, hard exudates, cotton wool spots, and disc edema. As against, if you have any intracranial cause for disc edema, you would generally not see microaneurysms and you won't see too many superficial hemorrhages, whereas you will see a disc edema which is without any retinal signs. Coming to non-arteritic AION, you would see disc edema which is of pallid disc edema, what we call it typically. So you have sectoral edema as well as disc pallor, and the disc appears small, and you will have a typical scotoma that you have with a non-arteritic AION. So this is how you differentiate papilledema, hypertensive retinopathy related optic neuropathy, and non-arteritic AION. And then the fourth thing is about neuroretinitis or optic neuritis, and that's a condition where the visual acuity would be severely impaired, and the patient would present again with blurred disc margins and very limited retinal signs in that case too. A fourth differential diagnosis would be a central vein occlusion, but you can see lots of spattered hemorrhages all across the fundus along with the disc edema. Anything else that comes to your mind?
Ritesh sir, would you like to say something?
Not really, very nicely covered. It's eventually going to be a diagnosis where you keep ruling out one and then going to the next. Once you have done through all the clinical signs of looking at retinal changes and ruled out CRVO, hypertensive, then you look at your disc, get a field done, and eventually get a neuroimaging done to pick up your cause. So that's it.
Right, sir. So I think this would be the last question, because I'm really thankful to you for the covering everybody's questions pretty much in details. And the last question is that what is your opinion about impending vein occlusion? How do you differentiate an impending CRVO from hypertensive retinopathy or an established CRV from hypertensive retinopathy? Because I think this question is very commonly asked in the Viva questions too.
All right.
So,
first of all, I mean, it's a very difficult question to answer practically. I mean, a patient coming to you in OPD, let's imagine he has tortuous and dilated vessels. What do you do? I mean, at the most, you can check the blood pressure and see if his blood pressure is normal or not. And whether this patient is going to ultimately end up developing a central vein occlusion, we don't know. I mean, and you can't prevent it also if in case he's going to develop one. So best strategy in such cases would be to check the blood pressure and look for any cardiovascular risk factors. If there are any, you can advise the patient to go to the physician for the same thing. But I don't think there is any way by which you can predict an impending central vein occlusion, or somebody who doesn't have a vein occlusion now and is going to develop it within say 48 hours or 36 hours. It's very, very difficult to predict this.
Right. So, Ritesh, sir, would you like to say something?
No, I totally agree with Dr. Aditya. We also have this issue wherein you have this problem, you feel it's probably an impending CRV. The only thing you can do is investigate and keep him on follow-up. Because at this stage, the vision is also good. And you don't want to unnecessarily scare the patient also. And at the same time, you don't want to miss out if a CRV happens, but you have to be honest and tell them that you have to be very closely monitored. You can do a fluorescein angiography and look for sluggish flow, but you have to understand you'll be investigating all this in an eye which has yet not had any visual issues, and he has just come to you for a routine checkup and you picked it up. So advising an FFA, looking at venous drainage or sluggish venous flow to pick it up, probably practically we won't be getting it done, but theoretically you can do an FFA and confirm it.
Right. So, thank you so much, Aditya sir, and thank you so much, Ritesh sir, for this wonderful discussion and the presentation, sir. I am vouching for it that this presentation has covered the whole of hypertensive retinopathy components. So there's not much more that is required than this presentation, and rest of it is all been asked by the postgraduates. So they were diligently listening, and I'm sure they've made their notes because they actually message us by the end of the day that, the notes are ready and we are all set for the exams. So I'm glad it's helping you all. Thank you so much, Aditya sir, for your time. And thank you, Ritesh sir, for adding beautifully to the discussion.
Thank you, Dr. Santosh sir, and Ritesh and Rolika also. Thanks a lot for this interesting session, and thank you for your invitation. I enjoyed the show.
Thank you so much. Our next talk will be on March 9th, and that would be Pathogenesis and Classification of AMD and Clinical and Imaging Features and Diagnosis by Dr. Uni Nair. So we are moving on to the AMD component for the next few lectures, and we'll all see you there next.
Thank you.
Thank you, Rolika. Thank you, Dr. Aditya. Good night. Thank you.
Thank you, sir.